So, as an oncologist, I can tell you that for a long time, mental illness has been a passion of mine. I think one of the great things that we do in the Harvard Cancer Center, and specifically both at the Dana-Farber Brigham and at the Massachusetts General Hospital, is have wonderful psychiatric oncology programs that really are leading the way throughout the world in terms of treating patients who have a dual diagnosis of a mental illness and also cancer. And so, but this is an area which I think is a huge unmet need. And for me, I wear a couple of different hats. So one hat is I'm the chief of hematology oncology here at Massachusetts General Hospital. And I'm responsible for the academic clinical investigation that goes on at the MGH around cancer. The second is I'm the clinical director of the Cancer Center, and I'm responsible for the day-to-day operations of the 1,000 patients who are currently going through Yawkey right over there that you can see out the window. But then the third hat that I wear is, along with George Dimitri, I'm the co-clinical director of the Dana-Farber Harvard Cancer Center. So the consortium cancer center that comes together to try and do things that we otherwise couldn't do alone and really make a difference in the world of cancer and cancer medicine. And we all have a story, I think, of mental illness is so pervasive and so prevalent, and Kelly's going to get into that in her plenary, that we all have a story about dealing with mentally ill friends or family members who then have to interact with the healthcare system, and how absolutely difficult that is. When somebody gets a real serious illness, heart failure, surgery, or in this case, a real longitudinal illness like cancer, that can be so incredibly difficult to navigate. It's hard enough if you're not mentally ill to navigate the cancer networks. Imagine if you have a mental illness, or imagine if you're the primary caregiver of somebody with a serious mental illness. And so I think we're at a moment in time, and we came together and said, geez, we ought to have a symposium to talk about this. And I think the fact that we had to turn people away, we have 160 people in the room, and we had to turn nearly the same amount away from this symposium. I thought maybe we'd get 30 people. And it just goes, Kelly didn't, she was always confident. It just goes to show you that this impacts everybody. And for me, and I'm going to finish my opening remarks with this analogy, and this is what I want, the framework that I have for today actually is this. About 15 years ago in Boston, people within our great institutions came together and started looking at palliative care and integrating palliative care in the cancer clinic. And then about 10 years ago, we had an incredible investigator, Jennifer Temmel, who's sitting up here, who said, we have to study this in a systematic way, the care delivery. What about supportive care services is standard, and what's investigational, and what makes a difference and what doesn't make a difference. And with her vision, we have now launched within our great institutions some of the best healthcare services research on the planet. In fact, we're all going to go to ASCO next month, and the Cancer Outcomes Research Group, which studies palliative care, so Jennifer, now with Joe Greer, who's sitting over here to my left, they have 16 abstracts. They have oral presentations. They are leading the world in terms of an academic approach to integrating palliative care into cancer medicine. What today is for me is the beginning of integrating academic psychiatric oncology into the cancer medicine field. Here at the Brigham, the Farber, and the General, we're going to look back 10 years from now, from the collaborations that start today, from the research projects that start today, and we're going to have 16 oral presentations and poster presentations at all of our great meetings, because people in this room are going to come together and say, we need to study this in a systematic, rigorous, scientific, academic way, because our patients need it and our patients need to do better. And ultimately, it always comes down to this. It comes down to the doctor sitting across from the patient, and the patient asking the Doc, what can you do for me that will give me the best chance at the best case scenario? And the doctor only has 3 things that he or she can do. You can do the best supportive care, and hopefully you're doing that throughout the entire engagement. You can do the best experimental care, or you can do the best standard of care. And I would argue that for patients with severe mental illness, it's not clear what's the best supportive care, what's the best experimental care, or what's the best standard of care. And the research projects that come out of today are going to establish that what is the best care for patients, and it's going to change the way we think about severe mental illness and cancer. So that's my little introduction, and a little call to action, a call to arms. So today's format, it's all in front of you, but for the next hour, we're going to have a combination of a panel discussion where we're going to hear 2 stories of 2 different patients who had severe mental illness and interactions with cancer medicine. We're going to hear each story first over the course of about 10 minutes, and then we're going to you can ask some questions about it. We're then going to break. Ilana's going to introduce an exercise, and then after that exercise, we're all going to come together and discuss what we would like to see as the great priorities coming out today. So I would like to ask all of the folks, and we'll just by way of introduction, if we could just go down the row and for the panel members to introduce themselves, who they are and what they do, and then we'll come back and start the discussion. So,
my name is Keri Brenner. It's a pleasure to be here, and I am double boarded in psychiatry and palliative care.
Hi, I'm Lipika Goyal. It's definitely a pleasure to be here. Thank you, Kelly and Dave, for putting this together. And for everybody else who put this together, I'm a medical oncologist in GI.
I'm Joan Archibald. I'm here with my husband, Henry. We're the parents of Jonathan Archibald, who was bipolar and also developed cancer of the rectum.
I'm Anna Farago. I'm one of the thoracic medical oncologists. Hi, I'm Caryn Metzger. I'm a psychiatric clinical nurse specialist, and I worked with a patient who received care at MGH for lung cancer.
So if you could pass that back to Joan. I'm going to ask us to start with Jonathan's story, Joan, if you would, and give us your story of how you first interacted with the cancer medicine service here at MGH.
Mm-hmm. All right. My son Henry and my husband Henry and I have 2 children. David was the oldest, and Jonathan. And Jonathan, when he was 16 years old, we found out that he had bipolar illness. And he was in the beginning of his sophomore year of high school at that time. He was hospitalized, and he eventually stayed for 6 months at Westwood Lodge, which was a very long time back in those days. They kept people in the hospital, but no longer. He went back to school. He wanted to go to a public school, but they thought that maybe he shouldn't, so he went to the Arlington School, which is at McLean Hospital. He went there for a year where he was with other teenagers, and he got very good care. From there, he went on to high school. He went to North Cambridge Catholic and graduated. And he wanted to go to college, and so he started going to a North Shore Community College and stayed there for a while, then transferred to Suffolk University, where he unfortunately decided he was going to run for president. And I knew that was a problem because he was headed for mania. And so he had to drop out of that school. But eventually, he did start going to UMass Boston and taking, for example, 2 or 3 classes at a time. He was eventually able to graduate, and we were tickled pink. So he struggled back and forth for many years, doing all right, and then getting sick. Sometimes he wouldn't take his medication. He thought perhaps he was cured. And so he would give it a trial and found out that he wasn't. And sometimes he'd speak to his doctor and ask to have the medication lowered. And the doctor was very nice to him and said, well, let's give it a try. And so they did. And shortly after that, Jonathan would get sick. So he was back and forth into many hospitals, Mass General, McLean, and whatever ones are around. So anyways, what happened was that he was beginning to have some symptoms. But, you know, people who have mental illness are usually so concerned with that problem that they, you know, kind of overlook any other medical issues. And so it was a while, but he finally went to a doctor's appointment. Unfortunately, he did not get to see his doctor, but he saw someone else. And he was given a rectal examination, which was extremely painful to him. As a result, although he was told that he needed to have a colonoscopy, he put it off because he thought that the colonoscopy was also going to be painful. So there was a delay there. Eventually he went and we found out that he did have rectal cancer and that it was at an advanced stage. We had an excellent Dr. Ferris and Dr. Goyal right here who worked with us. They were excellent. And I remember when Jonathan was at an appointment and the doctor, Dr. Ferris, suggested that he be admitted that day and stay and have his chemo as an inpatient. And if you remember, Dr. Goyal, it was really terrible because Jonathan was really frightened and he disappeared. We didn't know where he went. And Dr. Goyal stayed long after the office closed with me. She was going back and forth doing her work and was so patient. Jonathan eventually came back, and after talking to him, we finally convinced him to do that. So he went upstairs to the Lunder building to have the chemo. Dr. Irwin asked me to mention about how we had to advocate for Jonathan. When he went up to have that done, he was seen by a very young doctor. I happened to be I told him that I was going to stay overnight with him because he was so afraid. So I said, don't worry, I will stay with you. But I was out of the room, and when I came back, he told me he wasn't going to have the chemo. And I said, well, what are you talking about? That's what we came here for. He said, well, the doctor said that there's a possibility that I could have mania because the medication that I'm taking might interact with the chemo. And so he was very, very upset. And the nurse came in to pull out the IV. And I said, now, please, you know, we've done so good so far. Let me talk to Jonathan and see what we can do. So I talked to him, pleaded with him, we prayed, and finally he decided that he would have it. And so the doctor came in, he told him that, and he had the chemo. Everything worked out fine. So that was his first experience with that, and I really had to be his advocate. There was another time I had to be an advocate for him also. He had to have a colostomy. So he had the bag on the side. What happened was that it prolapsed, and the tissue came way outside of his body. And we had to take him to the emergency room here. So it took approximately half an hour for the doctors to put some salt on it. Sugar, it was sugar. They put a little sugar on it to help with the moisture, to try to get rid of some of the moisture, and then they pushed and shoved. They finally got it back in place. And they told my husband and I that we were going to have to learn how to do this because it probably would happen again. So we just looked at each other, you know. We said, oh, I don't know how that's going to work out. But then it happened to him again. Back to the emergency room he went. This time it took about an hour for them to put that back in place. Jonathan was very good because he often wanted to advocate for himself because he had had to do that over the years. And he said, there must be another way. He said, maybe the surgeon can operate and do something else to fix this. And he kept calling the office. But as you all must know, people a lot of times overlook the mentally ill. They feel they're just being pesty or, a bit of a problem, and he was unable to get an appointment. So what happened was we had an appointment with Dr. Irwin in her office. She was his psychiatrist, and Jonathan told her the story. And she said, well, you are entitled to have a consultation. And she said, let me see what I can do. So she got on the telephone and she called the office, and within about 5 minutes, she had made an appointment for Jonathan. He went and spoke to the surgeon. The surgeon said, let's try something. I think we can do something about that. And they did, and it was repaired. And after that, it never came out again, so that was wonderful. One other thing I'll just mention to you is he had nephrostomy tubes, too, which drained his urine. And this was a problem because the tubes would leak. He was at home at the time with us. The tubes would leak. And it was because he would move around in the bed at nighttime, and they'd get dislodged a little. And so we'd have to go back to urology and have the tube put in. He had to have it put in every 6 weeks anyways, but there were times when we had to go in between. Well, it got to be that people thought that Jonathan was pulling the tubes out. And I had to advocate for Jonathan and let everybody know that he was trying his very best to take really good care of those because he knew how important they were. So there were many times that we had to advocate for Jonathan, but he was worth it, we felt. And so we did the best we could. And he came along pretty good for a good while, was at home with us, and we still enjoy doing a lot of things together. He was my buddy, and I always enjoyed his company.
So, thank you, Joan. So, Lippy, give us the overview. From a medical perspective, what happened to Jonathan, and what was the course of his rectal cancer?
Yeah. So I took care of Jonathan in the last couple of months of his life. I took over the care from another physician. And, Jonathan ended up having cancer that spread outside of his rectum. And we had many chemotherapy choices that we could offer to him. And he did get some chemotherapy and he did get some radiation, but I think he was also afraid of getting more chemotherapy. And one of the tough things as a medical oncologist was we have these other treatments that we can offer that we would like for him to be able to get, and they work. But at the same time, as Joan was sharing, he was also very hesitant sometimes to get chemotherapy. And I think one of the things that is really important, there are 3 points I'd say I'd like to make today. One is, as a medical oncologist, one of the things, and as a doctor in general, one of the things that's so important is we want to always respect the wishes of our patients. And when someone is mentally ill, I think as a medical expert, as opposed to a psychiatric expert, you wonder, do I really know what my patient's wishes are? And Jonathan was a compassionate, intelligent, and lovely person, and he was very clear about what he wanted. And I definitely could not have done any of this alone. I really learned so much from Dr. Irwin the entire time I was taking care of him. And without having his mental illness under good control with the excellent care that she gave, it would have been very hard to really have the confidence that what we were doing was in line with what he wanted. And he said many times that he was not afraid of dying. He articulated many times that he understood what the impact of getting chemotherapy was and not getting chemotherapy was. He also shared that his faith was very important to him, and what having a collaborative approach with psychiatry and palliative care and medical oncology, all of us together, I think we were able to all have the confidence that in the end, whatever choices he made, we were very much respecting his opinion. And that was also really important for Joan and Henry and Caryn and all his family members to feel that we were really able to listen to what he wanted, and his thinking was clear enough that we could feel that we were respecting his opinion. The second is that expertise really matters. Having someone that has the expertise to manage bipolar disorder, having that person as a part of your team was really key. And also, this may be a slightly unpopular thing to say, but unfortunately it's true. It's what Joan was saying about the fact that people often overlook the mentally ill. And the fact is, there are certain populations in medicine where the patients, what they say, takes a discount, and their opinion doesn't hold the same weight as other populations. And one of those populations, unfortunately, is the mentally ill. It also happens sometimes when people have physical disabilities. It happens with certain ethnic groups. It happens with certain socioeconomic groups. It happens sometimes when people don't speak English. There are all sorts of biases that we recognize that we come to the table with. And I think one of the great things about having strong collaboration between psychiatry and medical oncology and palliative care in this setting is helping to make sure that our patients, what they feel doesn't take a discount, that we really take into account what their opinion is, and we're really able to respect that and bring that into the fold when we make decisions.
And Keri, do you want to give us, from your perspective and from a palliative care and end-of-life perspective too?
Yeah, so within palliative care, we actually were able to meet Jonathan quite upstream, about 2 years before he died at 43 years old. And I always like to think about first what kind of a person has the disease rather than the disease that has the person. So I asked around many of my colleagues, and they described Jonathan as very likable, compassionate, generous, gracious. He was always giving gifts to other people. Even when he was admitted on our inpatient psychiatric unit at MGH, he was telling us how he was trying to help the other people on the psychiatric unit feel better. That's how other-centered Jonathan was. He really drew people in, and they cared about him tremendously. I think that from a palliative care perspective, we always think in terms of patients' quality of life. And both serious mental illness and serious medical illness, in Jonathan's case, are both not curative. We know that they're both chronic, they're life-limiting, they result in debility and functional decline, often with a disproportionate amount of time in the hospital or institutionalizations, on multiple medication trials, bearing a lot of physical and emotional suffering. Jonathan experienced that as a teenager and then was experiencing it again with his serious progressive cancer. And we also know, though, with both serious mental illness and serious medical illness, that with optimal treatment and optimal supportive care, patients have better outcomes, better functional status, better quality of life. Some of the challenges that we faced were the fluctuations of, as Jonathan got sicker physically, his mental illness also became more symptomatic. That's why it took a village. It truly did, to give him the best of care. And I'd say it took a consistent village, because you heard from Joan here that when new people would come in, it would sort of disrupt things for a bit, but having the presence of Kelly, our palliative care nurse practitioner, Jason, was the primary person that saw him over the 2 years. His parents were a very stable presence, the same oncologists, to give clear, simple messages and the reassurance that Jonathan often needed time and time again, and to be his advocate. We found that things that were practical challenges, Jonathan really suffered from, he thought a lot about body image. Something like a colostomy bag was horrific for him to consider, thinking about stool being on the outside of his body. What would that mean in terms of how other people would think of him? And that's why initially he delayed what would have been perhaps a curative surgery for his cancer, because he was so concerned about that. Also with the nephrostomy tubes, as Joan mentioned, sometimes they would be bothersome to him. He thought about, I'll never be able to swim again having these in. The tubes would sometimes get caught in things like the doorknob unknowingly. In one 2 to 3 week period, we had to change the tubes every other day. That was the frequency of us needing to help readdress that. And so having a consistent team that could be adaptive with him in the moment with what he needed was very important.
So in the interest of time, we're going to come back to Jonathan's story, but I want us to get a different story and a different take so that we can have a slightly different perspective as we begin our discussion for the second half of this hour. So, Caryn.
Sure. So I'm going to refer to the patient as Sally. Is a 50-year-old woman with schizophrenia, about a 20-plus year history of schizophrenia, and a long history of trauma, who I'd been seeing since the beginning of 2012. And in May of 2015, her group home had contacted me saying, she's really coughing a lot. I'm really concerned. She won't go in for a medical appointment, but we think she'll listen to you if she comes in to speak with you. So I had them send her in, and, clearly she had a horrible cough. Her O2 sats were low. So I said, Sally, I'm really concerned about you. Can we go over to the medical clinic and just have you checked out? And she went willingly, which was great. And they said, let's do a chest x-ray. And on the chest x-ray, she had a very large mass in her lung. And the doctor said, we really need to get a CT scan. We need to find out what this is. And she was like, no, I'm all set. I don't want to see it. And we offered to show her the x-ray. There really is something there. We need to do something about it. So she kind of begrudgingly agreed to go get the CT scan if I walked over with her. So I started walking with her, and she literally ran out the door of the hospital and to the bus stop, got on the bus, and was gone. And she's someone who's on clozapine, so I see her monthly, and every month when she came in, we would discuss this and try to get her to seek medical treatment. Meanwhile, the cough was persisting. She was losing a lot of weight. She had lost probably about 30 pounds in a 6-month period. It was literally like watching someone die in front of you. And we had numerous team meetings about what to do about this, because when we discussed this, she would say, no, I don't want that. I don't want that. I never thought I would live this long. I thought I'd be dead by now. And so it was, is she competent to make this decision? Is she not competent to make this decision? Are we overstepping our bounds if we force her to do something she doesn't want to do? And so this went on for about 6 months, and I, fortunately was sent to a grand rounds at MGH by my supervisor, where Kelly Irwin was presenting, and afterwards I asked if I could speak to her about this case. And so we began coordinating. In December, she was coughing up blood at her group home on the back porch, but refusing to be seen. She wouldn't come in early to see me because she knew what I would recommend. So I actually went to her group home to discuss the issue with her, having planned in advance that if she wouldn't go voluntarily, that we would Section 12 her to MGH for a medical and psychiatric evaluation. At that point, she didn't associate her illness with potential death. So, her psychiatric illness was intruding upon her ability to make decisions regarding her medical care. So she went, she didn't run out of the house. She waited for the ambulance and went to MGH. In the process of getting all of this coordinated, I called Kelly. We arranged between medical and psych at MGH. But the time leading up to this was very, as a provider, you feel so helpless. You are actually just watching your patient disintegrate. And, no one really has a clear answer of what you should do. Like, you want to get this person help. But again, there's that, is she competent? Is she not competent? And as much as mentally ill people often don't get the care they need, they also deserve the right to make decisions about their medical care if they're making an informed choice. And a lot of the time when we would talk about this, she would say, no, I understand. I'm gonna die. It's fine. But, which again can be a little questionable too with, when a normal or average 50-year-old person decide to fight this. But on the other hand, she grew up in a family where medical care wasn't something they sought. She was taught that you don't seek medical treatment. So there's this big back and forth and just very much a feeling of helplessness among most of her providers. She's very fortunate in that she's lived in the same group home for a long time and had staff there that she really trusted and felt comfortable with, and they were integral in her care as well, but also, again, she wouldn't listen to them or hear their appeals to her. So in, I believe it was early December of 2015, she ended up in the MGH ER. Kelly met her in the emergency room, and the process began.
So Anna, tell us a little bit about what happened and what the stage, the treatment, and the outcome.
Yeah, so I met Sally when she was admitted at that time at Mass General and asked to evaluate for a new possible diagnosis of lung cancer. And I think at the time I had met her, actually, she had, I believe she had had a bronchoscopy with a biopsy that had happened earlier during that admission. So around the time that I met her, we knew that she had a diagnosis of non-small cell lung cancer, and she did have a very large mass in the lung as well as some enlarged lymph nodes. And we got additional scans. We didn't see disease elsewhere, and recommended a surgical evaluation to really complete her staging. She did not want a surgery. She was very, very clear about that. And we ended up having several very long discussions in the hospital with us and I think with Kelly and her team present about really how to move forward, because we reached a little bit of a standstill about how best to complete our staging process and then recommend a treatment plan for her. And we ultimately agreed that we would not further pursue a surgical evaluation, and we instead decided to try to approach this with radiation and chemotherapy, which is also a very reasonable treatment option for stage 3A lung cancer. Initially, Sally really had a lot of fear about both the radiation and the chemotherapy, and we approached it really one step at a time and decided we'll start with the radiation and see how you feel. And then go from there. And we did that, and we were able to get the radiation started, and then we said, well, let's see you in clinic and see how you're feeling, and then talk about chemotherapy again. And I saw her in clinic, and she had a very reasonable experience with the radiation so far. She hadn't had any trouble, and in fact, felt that it was going well. So we were able to get her started on a weekly schedule of chemotherapy. And I think this was a really big step to be able to offer her this this treatment, which was really the best treatment that we could have offered her. I think that we built up a lot of trust over the time that we spent with her in the hospital and the one or two visits that we spent with her outside of the hospital, even before we started any chemotherapy, to even be able to get to that point to start treatment. And then once we did, we continued regular visits with her once a week. And I think the frequency of those visits was very helpful for her. And the fact that every time she came, she was there with a staff member from her group home. So she felt that she had a support person with her. And we were able to get her through a definitive course of chemotherapy and radiation for a stage 3A lung cancer. Her symptoms got much better. I think that helped too to reinforce the positive outcome for her. And I've been seeing her regularly since then for surveillance scans and following her. And I would say the other thing that I think helped with my strategy to get her through all of this, in addition to the regular frequent visits, were excellent communication with her group home. We would, after every visit, exchange emails about what was going on, and Kelly was involved with those too to keep everybody up to date and on the same page. With Sally, we would address one problem at a time. We would try to be very careful not to take on too much in these conversations that could get very complex, but instead keep it sort of simple and straightforward and focused on specific goals one at a time. So I continue to see her. She's continuing to do very well clinically, and I think now she's at a point where she feels very comfortable coming into appointments. We, I think, know each other fairly well at this point. And when I see her, I do ask her about her symptoms of schizophrenia, and she's able to tell me how she's doing with that, and knows that Kelly and the team are available to her.
Anna, just one clarifying question. So, unlike Jonathan, who presented with advanced disease, what chance of cure does somebody with 3A lung cancer have? Or if not cure, what chance of being alive 5 years down the road?
Yeah, so that's part of the very challenging part of the conversation around an initial diagnosis of stage 3A lung cancer. Even with the most aggressive treatment, such as this, her chance of 5-year survival is about 10 to 20%. So you in these situations, we want to offer somebody the most aggressive care possible to hope that we can get them into that 10 to 20% group. But we know going in that unfortunately the majority of patients will relapse with metastatic disease even when we treat them as aggressively as possible. And that's a very hard conversation under the best of circumstances. So it was even more challenging here.
So in the interest of time, before we start a question and answer period for the panel, we actually want to go through an exercise. And to do that, Ilana Braun, who's the Director of Psychosocial Oncology at the Farber, will introduce that.
Good afternoon. It is such a pleasure to be here today, and I want to thank the panel for so poignantly describing these stories of, on one level, challenge, but on another level, incredible successes. Successes in meeting the patient where they are, not providing paternalistic care, but care that was responsive to their own desires, and care that required collaboration across institutions with family. I think it really is just fantastic. And I think that these stories probably don't encapsulate mental illness and cancer across the spectrum, because mental illnesses differ, cancers differ, family systems differ, clinic systems differ, and unfortunately community resources differ. But I'm hoping that these two stories will serve as a springboard for an exercise in helping us to identify the key priorities that we together can move forward in this symposium and also thereafter as we work to narrow the disparities between the experiences of people with mental illness and those without when confronting a cancer diagnosis. So with this in mind, I would like to take about 5 minutes, and you may not know the people at your table, you may know them. Please introduce yourselves to those you don't know. What is really fantastic about this symposium that Dr. Irwin organized is that it is so rich. People are coming from many different professional backgrounds, personal backgrounds, and so I think this will make for a really nuanced conversation. So perhaps take 5 minutes to discuss the key priorities that we should advance for the rest of our time together. And perhaps one person at the table could be a scribe, and the other could be a reporter. So thank you.